There you go. That looks good. Good stuff. Okay, good afternoon, everyone. I'd just like to welcome everyone here for the final OC3PR from Critical Care Services for 2020. And that truly has been a challenging year. As I like to say, the only thing that's been more challenging is finding the perfect gift from Mike Sullivan, the man who truly has everything. Although the team here at CCSO has been doing pretty good with this webinar technology, we're still learning. We're exploring some new options such as Slido to help with question submission. But for the time being, we're still going with the process of having you submit your questions to the Q&A heading. Today, it'll be Dr. Neill Adhikari fielding the questions, as well as Dr. Mike Sullivan taking the plunge, who's still struggling with that thing called YouTube, as he likes to say. What is that? Please do your best for those who are listening to keep yourself muted. As always, we welcome you to send in ideas, suggestions, and tips to the email address info@ccso.ca. Just so you know, we've taken several of your suggestions with planned webinars in 21, including that on the COVID-19 vaccine, PPE and staff protection, as well as the medical management of COVID-19 patients. The first one we're going to be hearing in 2021 will be from Scarborough Health Network, who, if you aren't aware, have been managing over 200 ICU patients with COVID at their 3 sites. That's almost 1 in 10 of all the cases that have occurred in Ontario. I personally look forward to hearing how they've done it, what they've learned, and what we should know. We again encourage you to follow CCSO on YouTube and Twitter, as well as visit the new website that's truly up and running, and where you'll be able to find previous webinars there. I'll remind you, there's always an opportunity to send in your questions before talk as well. Finally, we truly value everyone taking the time to fill out the evaluation survey at the end. It helps us refine what we're doing for the future webinars. We're also working on getting these webinars eligible for CME credits, but I trust everyone appreciates that takes a little bit of time, and time is truly what's in the shortest supply these days. Today's the third and final webinar that will focus predominantly on the respiratory management of COVID-19 patients. We are welcoming back our speakers from the previous 2 webinars on this topic, and that is Dr. Stephen Lipinski and Dr. Eddie Fan. Dr. Lipinski is a professor of medicine at the University of Toronto and the director at Mount Sinai ICU. He certainly has had a distinguished clinical and academic career in several areas, including pulmonary illness, continuous dialysis, as well as mechanical ventilation. Dr. Fan is an associate professor of critical care at the University of Toronto. He's an intensivist within the University Health Network and is currently the medical director of the extracorporeal life support program at the Toronto General Hospital. His academic work focuses on advanced life support for respiratory failure, as well as patient outcomes from critical illness. Gentlemen, I'd like to welcome you both again to OC3PR and for taking the time to help us discuss COVID and respiratory related issues. Today's going to be a little bit different in that we will present some questions, and we look forward to hearing from both of you on each of the questions to get 2 different perspectives on each of them. We'll also hope to have some time at the end to take questions that people are free to submit, and we'll do our best to get them asked and answered today. I also like to introduce Dr. Neill Adhikari, who has put together some of the questions and put them in a logical fashion, the usual way, and he'll work with all of us to help ask them. So Neill, I just want to invite you. Those who don't know, Neill is also an intensivist who does his best to make the world a better place. Neill, I'll hand it over to you and we'll get going on this.
Thanks very much, Dave. And thanks very much, Stephen and Eddie, for coming back. Looking forward to answering some questions that have been asked since your webinars. So we'll start with some related to the pre-intubation management of patients with COVID, and you can see them on the screen here. I guess the first one is, what factors influence your decision to choose an oxygen mask, nasal high flow cannula, or CPAP for non-invasive respiratory support? And the second tiny IPC question is, do you think all patients on nasal high flow cannula with COVID-19 ought to be wearing a face mask? Steve, maybe you want to start. Steve.
So I guess I'll start. So what factors influence your decision? I guess lots of factors: patient factors, physician factors, equipment factors. So there's really no one answer. Some of the difference between oxygen mask, high flow, and CPAP is related to oxygenation. Some of it is related to patient comfort, and some of it is related to availability. I'll give you an example. Yesterday, we saw a patient in our emergency room who was on high flow at 60 liters with a Tavish non-rebreather mask over it, setting at about 91. And we wanted to move her up to the ICU. So I turned the 60 liters of high flow nasal oxygen down to 30 liters, and she desaturated down to 82. So that's a problem. Firstly, I don't think we'll get high flow running for very long at that rate on a cylinder. And also we don't want 60 liters an hour running in the corridors and in the elevator. So that makes transport difficult. So for her, Tavish was the optimal mode of oxygenation, but with the Tavish mask, the non-rebreather alone, she couldn't keep her sats above 85. So ultimately we had to intubate her and bring her up to the ICU in that way. So I think there are patient factors, there's comfort, there's what actually works, and there are also issues related to transport, where you are and what equipment you have available. And in terms of wearing a face mask, probably is a good idea to try and reduce dispersion of potential aerosol into the room by wearing either a procedure mask or surgical mask or an oxygen mask that's not connected to anything. You can keep that dispersion local around the patient's face rather than all over the room. But it's not something we're doing on an absolutely routine basis at the moment.
Thanks, Stephen. Eddie, anything to add to that?
No, I agree with Stephen completely. I might just add, like many things in the pandemic, we're getting more data as the pandemic evolves. And, there's now, more data suggesting perhaps high flow nasal cannula is not as aerosolizing a procedure as we thought at the beginning of the pandemic. So some work from Michigan that has been published, and a systematic review led by Holger Schoenman on behalf of the WHO, suggesting that perhaps, in fact, it may be less aerosolizing than Venturi mask. So I think, again, just to keep an open mind and some healthy skepticism, sort of for these unknown unknowns, but certainly as more data becomes available, we might shift our thinking about some of these things based on evidence.
Great, thanks. And as either of you, we talked a little bit about this when Stephen presented, but as either of you, since the last 2 weeks, I guess, because things are changing quickly, have any experience with helmets, helmet CPAP? And any comments about that?
Yeah, we've started playing around with helmets. We've only put it on one non-COVID patient. We had a simulation, I think, yesterday with a bunch of RTs. And definitely you can achieve, a good non-invasive ventilation with what looks like minimal flow, minimal air leak. Interestingly, we found that the effect was different with different ventilators, but we haven't actually got them onto COVID patients as yet.
We've had it on three COVID patients, and in the classic rule of thirds. So one, it was great. One, it didn't really make a big difference. And one, it was a spectacular disaster. So we're sort of slowly increasing our experience with the helmet. And as Stephen said, there are some challenges depending on obviously the patient factors, what kind of ventilator you use to pressurize the helmet, and these sorts of things. But we're sort of learning as we go.
That's interesting, Neil, because that was going to be my question about the transport issue. And I'm wondering, is perhaps that a consideration now? I think we're all learning about the helmets, and that's going to be a challenge. But especially if you were transferring from another site to a more definitive location, I'm wondering perhaps that may have a role in being able to do it somewhat safer. But I guess that's a pretty hard question for Stephen and Eddie to answer with it. So perhaps that's something we can come back to in the future.
Great. Next question has to do, it's an interesting question that came from an audience member last time. And the observation was that during the first COVID-19 wave, many patients were rapidly intubated when they were on high FiO2, for example, a TAVR mask or a high ox mask or something like that. And some of those patients were found to have fairly compliant lungs, which was described and written up. And then later on, as hospitals and ICUs became more crowded, many patients were managed maybe in a level 2 unit, in some places on a ward, with CPAP and nasal high flow cannula. And when those patients needed intubations, when some of them failed, the compliance was often found to be low. And the question relates to whether you think that that difference relates to the use of maybe injurious non-invasive ventilation or non-invasive respiratory support, to be more precise, pre-intubation, or is it more likely just sicker patients getting sicker and probably not related to how they were supported beforehand?
So I'll answer first because I'm going to give a very simple approach, because I know Eddie's probably got a highly sophisticated answer to this. But I think it's just a matter of timing. The early patients were not that sick when they were intubated, and now we're waiting till they have full-blown real ARDS with a low compliance before we intubate them. There was a period where patients were intubated just because their SATs dropped and no one wanted to do the intubation at 2 in the morning with limited staff. But who knows whether there's a component of P-silly or something else. Over to Eddie for that.
I like Stephen's answer very much, which I completely agree with. I think it's just a timing issue. And again, this sort of goes to the discussion that we had in my previous webinar about whether these L and H phenotypes are really phenotypes or really just phases of the illness. I think you might find a similar thing with community-acquired pneumonia. If you intubated patients early, their compliance would be relatively preserved, but if we wait on a patient until the community-acquired pneumonia leads to some lung injury, compliance might be reduced. So I think it's, I agree completely with Stephen. It's probably more a timing issue than a difference in the support strategy.
That makes sense. Thank you. Sort of a generic question on a couple of generic questions on intubation, some of which I think may have already been addressed, but factors in the decision-making around intubation and how protocolized has your approach become to this procedure compared to, I guess, pre-pandemic in terms of drugs, equipment, personnel, and sequence of events?
Okay, it looks like I'm answering first each time, and then Eddie can agree or correct me. So I mean, the big difference is the use of PPE and the careful use of PPE. And as things have evolved, that's really smoothed out. I mean, when we intubate now, we know what we're doing with the PPE. We make sure we're fully covered. And the standard is a patient fully sedated, fully paralyzed, RSI, to make sure they're not coughing, which I must say is different to my usual practice, which is pretty much everyone ventilated, non-apneic, so still breathing. But because of COVID, I've had to actually paralyze patients. But otherwise, I don't think it should be any different to the, as soon as you start changing things, doing things dramatically different, you're going to run into trouble. So all the usual precautions for intubation, but just making the people in the room have full PPE, the right people are in the room, the necessary equipment that isn't in the room is standing right outside the room with a way of communicating with the outside of the room, and have a plan of what you're going to do if things go wrong. And I never have a plan B because I number my plans. It's plan 2.
Thank you. Eddie.
Well, What can I say? I learned how to intubate from Dr. Lipinski, along with much of my critical care knowledge, so I can't help but agree with plan 1 and 2. Yeah, I think maybe the one other comment I might make is that I'm sure that we benefited at my hospital. I'm sure with some other hospitals in the region with an actual intubation team at the height of the first wave, and so they were managing these in a very standardized way, as Stephen described, with full PPE, the right personnel, the right equipment. We used standard video laryngoscopy after sedation RSI for intubation in these patients. And then there was a period of time where the team would actually wait in the room because this was an aerosol generating procedure before they were let out. But that's these things were, I would say, at least in our hospital, more standardized with COVID-19 and with these intubation teams than they had been previously.
Neill, can I just ask Eddie and Stephen, are you guys still using the intubation teams, or have you progressed to the stage where that both of you are comfortable leading that? I asked this as an anesthesiologist as well. I'm just curious to know.
So we've never had an intubation team at Mount Sinai. We just haven't had the volume of patients needing to be intubated. So it's always been the ICU team who've done it. And it's been preferably the ICU attending rather than the fellow. But our first few in March and April, it was one fellow who happened to be on every night there was an intubation, and she just took it on to do it. So she did half a dozen of them, and they all went very smoothly.
Yeah, we evolved out. So in the first wave, we had this dedicated team, and now as sort of non-COVID care has increased in the interim and is now on decreasing, anesthesia resources have been a bit more spread thin. So we've been, since the summer, intubating, much as Stephen said, ICU-led intubations for patients in the ICU, patients that we're consulting on the ward or in the emergency department after we've moved them to a safe location for that. But we've been resumed leading intubation of these patients from a critical care perspective.
I was wondering if you can comment on it. Like I think the move to video laryngoscopy was primarily around perceived safety of standing a little bit further away from the patient. And I'm wondering if either of you is aware of any data, maybe even simulation data that speaks to safety versus direct laryngoscopy, which at least for some practitioners is a bit more of a familiar technique.
So no specific data, Neill, to your question about COVID patients that I'm aware of, although I'm sure there's probably some available. I just haven't looked, but there is some data in the emerge and critical care literature preceding COVID suggesting that routine use of video laryngoscopy leads to better first pass success than direct laryngoscopy. So that might be partly where this recommendation is coming from, along with considerations, as you mentioned, for the specific case of how close you have to be for in the setting of COVID. But I would say that there is some pre-existing literature that suggests that you might have greater success with video laryngoscopy than with direct laryngoscopy. Stephen, if you have any comments.
Yeah, and I think if you're not comfortable with video, if the patient is completely paralyzed, it really doesn't matter if your face is close to their mouth, you're wearing a mask, you're wearing a face shield. The risk is minimal, but the standard has been, there's been a big increase in video laryngoscopy. We've bought a dozen new devices for our hospital, so they're all over and readily available.
Thank you. I think we'll move over to some questions related to ventilation. Maybe Eddie can take the first crack at one of these. I mean, this is first questions here is almost I think it's a question that can't be answered maybe, but it sort of speaks to a sort of a practical approach for how you might go about setting PEEP in the absence of an esophageal balloon or physiologically or some other method, maybe electrical impedance tomography or some method, some physiologically based method, how you might practically go about setting PEEP. And if you were to do a sequential sort of PEEP study, like some considerations around picking so-called optimal or best PEEP, whether it's saturation or compliance or oxygen delivery or whatever?
Yeah. So I think this is a good question. And as Neill sort of alluded to, not an easy question to answer. If you recall, I think if Luciano Gannoni were here, he'd be saying it's been 50 years and we still don't know how to answer this question, and we'll be talking about it for another 50 years. But I think from a very pragmatic approach, I would just use a strategy that your ICU is familiar with. And if that strategy happens to be, which I'm just going to take a guess, is probably some variation of a PEEP FiO2 table, whether that's from the ARDS network, from the Loves trial, or this sort of thing, that's a very simple and pragmatic way to set PEEP at the bedside. And again, because the data that we have about the use of higher PEEP is extrapolated from randomized controlled trials that largely use this kind of method for setting PEEP. And so this would be a very reasonable way as a starting point to set PEEP, which is, easy to do, it's easy to understand, it's probably something you've been using a lot. And I would say that using some of these more sophisticated measures, even at our hospital where we might have access to things like an esophageal balloon, to electrical impedance tomography, or these sorts of things, I would suggest those are sort of second line, or for Stephen, plan 2 strategies, where you start with something simple, which is setting the PEEP with the PEEP FiO2 table. And then if you're having challenges, then you go to sort of better individualize the PEEP setting by using some of these additional tools. And again, so along those lines for question 2, I would suggest that using oxygenation, which again, it's not perfect. And the key message here is to not let perfect be the enemy of good, is that pragmatically using oxygen saturation seems very reasonable at the bedside to set PEEP in these patients, whether you're doing an incremental or decremental PEEP trial. So where the PEEP either leads to desaturation, then you may go to a PEEP slightly higher than that if you're doing a decremental PEEP trial, for instance. This is a very good way and a very practical way for clinicians to set PEEP at the bedside, absent fancier tools that might be available or not available in your ICUs.
Yeah, and I don't add any commentary to Eddie on PEEP.
You're on mute.
Dave, curious from Ottawa whether whether you typically would use PEEP FiO2 table, which is basically what we use here, and then along with some empiric titration if that doesn't seem to work for the particular individual, or whether you would have use more physiologic techniques that like balloons or EIT or something like that.
Some of the more learned people are certainly using the balloon, and with them becoming more readily available and things, I suspect that will be kind of the next step for us. But again, we're often using some variant of what Eddie said, but looking at often gas exchange along with other aspects of how comfortable that they're looking on it, and what they can tolerate. So somewhat similar.
That sort of leads into our next question, which is in patients where we're not going to refer the patient for extracorporeal support, either because maybe they're over the age of 65 would be one example, or for other reasons. What would your approach be for a patient with severe or refractory hypoxemia in general terms?
Yeah, so I think so here would use some of the strategies that we've spoken about before. So again, in patients who might be responders or tolerate higher PEEP, and again, pragmatically speaking, that might just be at the bedside trying to use higher PEEP and seeing if that improves hypoxemia. That might be step 1 after the patient has already been sedated, deeply sedated and paralyzed, to minimize oxygen demand and to facilitate optimal patient ventilator synchrony. For patients who are not candidates for ECMO, then I think the next sort of thing to do would be, in the absence of a contraindication, would be to prone the patient. Again, and I say that not so much because proning is necessarily a rescue maneuver for refractory hypoxemia, but again, if we're delivering higher PEEP, higher airway pressures, maybe slightly higher tidal volume within the range of lung protection to try to fix refractory hypoxemia, it would be best to do that in a position or in a state where we can homogenize ventilation best and reduce any risk for ventilator-induced lung injury, and that would be in the prone position. So I would prone them. And then here, I think if failing that, things that could be tried, and again, they might not be available in all ICUs, would be to use something like an inhaled vasodilator, so inhaled Flolan or inhaled nitric oxide as a rescue maneuver for refractory hypoxemia. And it's interesting that this question has come up because we're just having a bit of a Twitter thing over the weekend about the use of high frequency oscillation. So for centers that still have high frequency oscillation, I think to recall that agree that the early routine use of high frequency oscillation for adults with moderate to severe ARDS is not recommended because of a possible signal for harm in oscillate and really no evidence of benefit in OSCAR. But in the individual patient data meta-analysis published by Maureen Mead and Neil Ferguson, in those with very severe hypoxemia and a PF ratio, say less than about 65, there seemed to be a benefit potentially for high frequency oscillation. So in those patients, we would certainly, who are not ECMO candidates, consider those patients for a trial of high frequency oscillation.
Yeah, and just two other minor things to add is optimizing cardiac output to minimize oxygen uptake in the periphery. So if they need more fluid or need more inotrope, something to consider. And then finally, to accept permissive hypoxemia and don't panic too much if the SATs are at a reasonably low level, but there's no evidence of organ damage. Then just accept it and move on. And I can answer this question easier than Eddie because I work on the west side of University Avenue where we don't have ECMO, and it's really dangerous to cross University Avenue. The mortality of crossing the street is probably higher than the mortality of ECMO. So we tend to go through a whole bunch of other maneuvers before we even think about calling across the street.
Thank you for that. A couple of points, and I think many places will have to dig through the basement to find their HFO devices, and the generation of respiratory therapists is that really was expert in managing them, along with physicians. Frankly, is maybe some have retired, some are a bit older now. So it definitely is something that I think you're right. If it's that IPDMA showed that it was beneficial in severely hypoxemic patients, but probably you want to practice it before you actually decide that you're going to use it on the first one. Can I ask you about your proning procedure? I suspect many centers now have become expert in proning simply because of volume, but have you changed your sort of technique at all, like using fewer people, for example, or learned any particular tricks to proning that only became obvious when the volume of patients being proned has gone up?
From my point of view, I think it's just practice. I mean, we're proning a whole lot more now than we did before. Previously, as Eddie said, it was more of a rescue maneuver. Now it's something that's done sort of fairly routinely and early, and everyone is just a lot more skilled and a lot more comfortable, but I'm not sure of any particular tips. But practice is the way to go.
I agree. I think one of the major barriers probably before the volume was comfort with proning a sick hypoxemic patient with ARDS, and I think with practice has come also more not only more experience with the procedure, but also the reassurance that this could be done safely with the right personnel in place, even when they have COVID, and so that certainly helps to erase an important barrier, I think, previously to prone positioning in some of these patients.
And the COVID patients typically are overweight to quite obese. So the practice has not been in easy patients, it's been in the more difficult patients. I think everyone's a lot more comfortable.
If I can ask the gentleman, do you paralyze routinely? And specifically for proning, at least on the initial one, do you paralyze before doing your prone at your institutions?
Not as a protocolized thing. In fact, my role mainly is stopping paralysis on a daily basis, just to see if the patients can manage. And generally it's 3 days down the line. Oh yes, look, we stopped the paralysis on Monday and she's fine. So I do more stopping than starting, but if you need to paralyze, then not a problem. But not being anesthetist, we don't have to paralyze everyone just to do something to them. We don't have a surgeon telling us they're moving while we're doing the procedure.
Yeah, we're the same, Dave. We wouldn't paralyze for the purpose of proning specifically, but as it goes, like most of the patients that we're considering proning in have already been deeply sedated and paralyzed. So that's by virtue of other reasons they're already paralyzed. But if, for instance, if we had a deeply sedated patient that we wanted to prone, we wouldn't paralyze them just for the purposes of proning.
Good.
Mike, any questions coming through from the chat or YouTube that you want to ask?
So far, we don't have too much, but I think people have probably just been engrossed in the conversation. So maybe we'll hear from a few folks now if they've got some stuff. I wanted to kind of come back to the question about intubating teams, and maybe just get a little feedback from the audience. Not so much. Obviously, each circumstance is a little bit different. But for the places that had them, would you like to see them come back again? Or do you feel like you've kind of got this now, and certainly at the ICU level, they aren't as necessary as they may have been the last time around? So maybe people could throw that into the box if they want to.
Okay.
So we'll look forward to that. I know I'm personally getting a little nervous if I cross University Avenue, hearing that that's a pretty scary place. So we have a similar challenge with the tunnel to go to our Heart Institute. It's kind of like, must be the University Avenue equivalent. But
this question has to do with sort of systems issues around transferring patients, even if they're not a candidate for extracorporeal support, which frankly many patients aren't, even that end up ventilated. Some considerations around when to transfer to a referral center, and thinking about this, that this may happen more often in the second wave than it did in the first even.
Yeah, I think, again, maybe just to reiterate some of the comments I made in the previous webinar, that we like to hear about referrals. They don't always have to be for ECMO. They could be referrals for non-ECMO reasons, or maybe just even, again, to touch base or ask questions about management, this sort of thing. We're happy to take calls. And it's better to call early than it is to call late. I think this, and certainly even in the non-COVID times, to hear the frustration from some of our colleagues who are referring a patient when one of the major barriers is that they've, they're too far into the disease process, or they've been ventilated for too many days, and that's sort of a major reason why they're not candidates anymore. So hearing early is better. And again, just to reiterate that we have transferred actually quite a few patients in this wave, to Neill's point, who are not candidates from ECMO right from the get-go. I could think of a young patient who was ventilated for quite a bit of time, so not a candidate for ECMO for that, and a variety of other reasons, but was sent to us from a referring center because they didn't have nitric oxide. And fortunately for the patient had a dramatic response to nitric oxide. PF ratio went from about 70 to 200. So we referred him for that reason. Sort of other, alternative ventilation strategies. Again, if you don't have HFO, or you're not comfortable with HFO, and that might be a rescue strategy for the patient, that might be another reason. So I think, again, the earlier we hear about patients, even if it's to touch base, it's probably a better situation than hearing too late about patients.
And we consider ourselves at Sinai a ECMO placebo site. So it's not uncommon that there's a call to the general for ECMO, and they're interested in the patient, but they don't have a bed. So they get referred to us because we're just across the street, and they come to us. And I would say 95% of the time they don't end up needing or getting ECMO. So we're not really the placebo arm, we're an active arm of the CSER trial, because not everyone got ECMO, but they got referred to the site. So that's our role.
And are you also, in terms of the timing of patients you're getting referred to Sinai, is it also typically fairly early in the disease course, or any comments about timing?
Yeah, I mean, I think we get two types of patients. One coming from very little hospital emergency rooms where we're getting them nice and early, they're fresh from the emergency room, or we're getting during COVID patients from overwhelmed ICUs outside of the city center, and there it's quite variable. Most of them are within the first day or two, but some of them have been a week down the line.
Great. That actually brings us to a bit to our next question, which is sort of around have you seen this kind of patient on the slide here, which is the patient who's lingering in severe respiratory failure? Still looks like they're needing proning for hypoxemia and muscle relaxant due to patient ventilator dysynchrony. Not getting dramatically worse, not getting dramatically better. Maybe it's, day 5 or day 6 of ventilation, and maybe for whatever reason, again, just to take ECMO out of the equation, they're not really an ECMO candidate. Have you seen this type of scenario a lot, and any particular thoughts about management other than doing the same thing and waiting?
Yeah, we've seen this kind of phenotype a lot, both in referrals that we get from clinicians, our colleagues in the community, describing exactly this kind of a situation and sort of saying, what do you think, what should we do? And we've seen quite a few of these, I would say, in our ICU as well. Sort of, as you said, not getting a lot worse, but not getting a lot better. And I think that in many respects reflects some of the data or the published cohorts suggesting that duration of mechanical ventilation, duration of ICU seems to be longer in many sort of reports of COVID patients. And I think, there's not much to suggest here apart from continuing to deliver, good evidence-based care to these patients and trying to prevent any iatrogenic complications when possible. I think, and also, I'm sure Stephen will bring up the point, is that the daily check of whether they need to still be on paralysis, or they still need deep sedation, some of the things that you're delivering, because every day is a new day and should be examined, where we can remove some of the things that we're giving that could have complications in the long term. But I think we certainly see these patients who seem kind of stuck, but there's not much else to do. We don't have any other evidence-based therapies at this point to speed up recovery in these patients. So to continue to deliver best evidence-based care and try to, make progress on a day-to-day basis in terms of weaning sedation, weaning mechanical ventilation, stopping proning, those sorts of things as the patient tolerates.
Now, Eddie, can I ask, have you seen any sort of late phase deterioration? There has been some talk on Twitter of a sort of cryptogenic organizing pneumonitis occurring after the initial ARDS. We've had one patient recently who got better and then suddenly got worse, who weren't sure if it was a ventilator-associated pneumonia, but diffuse patchy infiltrates. Gave him a short course of steroids with a dramatic response, and he's headed down to the floor after really looking quite sick all over again. And I'm seeing mention of this on Twitter, but no actual literature as yet.
Yeah, I think we've seen, and again, I think that's a good point, Stephen. I guess I was taking this as persistent in the Neill's point, sort of 5, 7, 10 days, which I would consider still short. But certainly we've seen some patients in the 20, 30 days that seem to develop this kind of thing. And we've given high dose steroids. I think I mentioned in our last webinar, like we've given them ARDS, like Lazarus type steroids, so high dose methylprednisolone for 2 weeks. And seen, again, some of them recover. Hard to make causal inferences that was necessarily the reason, but certainly commensurate with the steroids, they got better. But also patients who got the high dose steroids and didn't get better at all, or didn't change their situation very much at all.
Right. So I'm hearing that I think it's important not to expect this to have a long disease course initially, like not to think that all these patients are going to turn around quickly, and experience would seem to bear out, and data would seem to bear out that the mean duration of ventilation is often quite long. But also, as both of you have brought up, that there may be some patients with sort of, late phase or very persistent, or recurrent respiratory failure that happens much later, for whom steroids could be considered, and unclear whether it's really helpful, but might be in selected patients. Yeah.
Yeah. In terms of the corticosteroids, Eddie and Stephen, do you continue it just for 10 days, or do you wait till they're off the ventilator? It's interesting because hearing that the course of methylprednisolone, that was actually what we were using predominantly in wave 1. But I'm curious, do you follow the 10 days from the evidence, or do you go until they're off the ventilator? And then I think we'll go to Mike, has a question after.
I think we've been mainly a 10-day course, but because you do a 7-day week on the ICU, it's hard to keep track of that.
Yeah, we've been mainly following the 10 days of dexamethasone, and our pharmacists are great at reminding us, like all things that have a duration, of making sure that it stops after 10 days.
Go ahead, Mike.
Dave, we got a question from Sam Aurora, who says, would you want to hear about patients who clearly do not meet EOLIA criteria, example, are over the age of 65, for example, for a trial of HFO?
Again, like I think if you think that the patient is a candidate, or you want to know if the patient is a candidate, or we think it's going to be useful, then the only way to determine that is to have a conversation about it. So we're happy to hear about that. Again, I think it depends a little bit on the patient, their clinical trajectory, what other organ failure they have, these sorts of things. But we're happy always to discuss it.
Okay. Any other questions from the mic? No? All right. Well, our last question was a little bit off the respiratory topic, and was someone had a question about a specific drug. We've talked a little bit about corticosteroids already and how they might be used for not only in the very evidence-based early phase of patients with respiratory failure, but also in potential late phase ARDS. Someone asked about tocilizumab and whether anyone has been using it outside of clinical trials for patients with severe lung injury.
Okay, well, I'll start. So we actually use a fair bit of tocilizumab for non-COVID. We have a lot of CAR-T related cytokine release syndrome complications. So we've used a lot over the last year or so. And in wave 1, I know 2 of my colleagues used tocilizumab in 2 very inflammatory looking patients who did very well. Then around when May, June, some negative data came out on tocilizumab. So we said, well, no more of that. And now the REMAP-CAP preliminary data has come out that it may be beneficial. But I think when we're routinely putting patients on dexamethasone, it's less likely that we're going to see someone who may benefit from tocilizumab. But definitely an option.
Yeah, it sounds like much like Stephen's, we haven't really used it. We participate in one of the tocilizumab trials. So we enrolled a few patients and had some experience either providing placebo or tocilizumab. We did give tocilizumab in the last few weeks to a COVID patient who was immunosuppressed following a solid organ transplant. So that was on the advice of the transplant team and the transplant infectious disease team, and we actually measured IL-6 levels in that patient before initiating tocilizumab. Now that's a research assay and obviously a very specialized circumstance. So just to say that we did do it, but otherwise, routinely we've not been giving tocilizumab to patients outside of a clinical trial.
Yeah, neither have we. Lisa, I don't think we've given it. I think our pharmacists would probably prevent it from happening, but
it's an interesting question, Neil, because I think we're going to get a lot more of these, and there's been certainly some other treatments that have been advocated that we hopefully will discuss one of the future webinars. You know, the anti head lice medication that
Ivermectin.
thank you. It's being advocated, and I guess it will ways to be seen what some of the evidence is. I don't know about you guys, but I'm getting asked about some of these by a lot of people frequently now, and it's kind of hard to keep up with all the Twitter feeds and things as such, but that's why hopefully in our medical one, we'll be able to answer some of these questions as best as possible.
I will say about tocilizumab because I just from WHO meetings that they are planning a sort of a meta-analysis, a trial level meta-analysis with collaboration from all the study investigators, because the REMAP CAP study stopped early for potential benefit after not a whole lot of patients, actually, maybe around 300 or so. But there have been other trials that have been at least statistically negative for the primary endpoint. So it's probably important to explore whether the drug works and in whom using a larger data set of randomized patients. I think it's not clear, but I think probably that answer should come in the next month or so. And that was it from the questions from the audience. It's just approaching 10 to 2 here. So I'm not sure if there are any other questions in the chat or in on the YouTube channel, but which we can ask now.
I don't have any other questions.
So
thanks very much, Eddie and Stephen. I'll hand it over to Dave, maybe.
Well, I just want to say thank you as well, gentlemen. Certainly has been a lot to ask of both of you to come back, not once, but twice. And certainly we're very appreciative of you taking the time to answer the questions and help us address some of the concerns that our brethren out there who've been dealing with this on the front lines have had. So I just want to remind everyone to take the time to do your best to answer the survey. That is helpful for all of us. I also invite everyone back in the new year for various talks that were already alluded to, including about our colleagues in Scarborough, as well as on the vaccine, as well as on medical management and personal protective equipment. I just want to wish everyone happy holidays and hope everyone has some downtime to enjoy things and reflect on things. It certainly has been one of those once in a lifetime, if not once in every 100 years. I think the way that Ontario's responded, certainly where most health professionals have responded, is something we can all be very proud of. I know everyone has given of themselves, taken away time from their friends and family. And it's something we should all be proud of. I'm very appreciative of people like Eddie and Stephen, as well as Neill and Mike and the whole CCSO team that have done this on their own time. And that's something I think we can all be proud of. We're here to help. We're here to listen. And again, I'm appreciative of what people have done. I would hope everyone stays safe, spend some time with those dear to you if they're in your bubble. I think we all recognize how precious these days are. So spend it with your loved ones, stay safe, and thank you again for participating. Mike, any final words?
No, Dave, I just wanted to thank you in particular for all the work you've done fronting these webinars. My thanks again to Stephen and Eddie. As you mentioned, this has been very gracious of them to offer their time and help us all out. And I'm happy to see us functioning more and more as a community. And to your thoughts, Dave, I think we need to be out there trying to take care of each other for the next little while, because it's been hard and it will continue to be hard for a period of time. And we're going to get through this by helping each other. So happy holidays. And we'll look forward to seeing you on the 12th of January.
Finally, thanks to our audience for engaging and asking great questions. And yeah, take care.
Thanks, Neil.
Bye-bye.
Bye.